Okay, so for the orientation slideshow, we have to go through this, so just bear with me, okay? Um, okay, so online to orientation online nursing courses. What is online learning? Of course, that's utilizing a computer and the internet or a tablet and the internet to complete your educational program. You have to have reliable internet. If you do not have reliable internet, then you need to figure out how to go to campus to have reliable internet, especially for quizzes and exams. Okay. Or you may need to think about taking an in-person course instead. Okay. I will give you feedback on things. You will have weekly homework. That is your responsibility to keep track of, okay? Discussion post. You will have a quiz next week over this week's material. It will not be about the orientation stuff, just about the PEDS material that we'll go through, okay? Your quizzes will always be about the material from the week previous, okay? And we will always do the quizzes at the beginning of class, okay? Okay, so if there is an issue, first start with me, okay? So if you cannot get into any of the handouts, if you can't get into, a PowerPoint, or you can't get into the course for some reason, start with me, okay? And I will try to get you to the right person, whether it's IT you need to talk to, or somebody on your campus, or you need to talk to Professor Bogart, the course lead. Okay. This has Professor Morris's email on there. She must have edited the PowerPoint. Okay, so you will contact me first. My email is in the welcome to Pediatric Nursing Week 1 announcement. Okay, that is where my email is. It's brooke.becker@fortiscollege.edu. My cell phone is also there. Okay. If Professor Bogart, myself, or your campus faculty cannot figure out what we need, then we get a hold of Dr. Brown. Okay. Or I might email you back and let you know, okay, we need to talk to Dr. Brown about this. Okay. So her information is here. She will not answer usually her student cell phone line over the weekend. So if you need something from her over a weekend, email would probably be the better route. Okay, so like I said, I'm your first contact. If there's an issue, you can email me, you can Canvas message me. Like I said, in an emergent kind of situation, you can text me or call me. Make sure you send me a text before you call me, because I get a lot of spam kind of things that I'm not great about answering phone calls if I don't know the number. So text me first and let me know, hey, I'm going to call you. This is, so and so. Okay. I enjoy your feedback. So at the end of the course, there will be surveys. We go through those. I utilize those to kind of gear my teaching skills. So go ahead and share your feedback. Okay. Okay. So let me know if there's something going on in your life that is impacting your schoolwork. Okay. Communication is going to be the number one thing that helps me as your professor to help you out, okay, and to help you to be successful. We want to be respectful and courteous to others in class, okay? So be respectful in your discussion posts, be respectful in class, be present in class. Don't use slang or anything like that, okay? And don't type in all caps because it seems like you're yelling at everyone, okay? Your, oh, hang on, I got chats here. You guys aren't seeing the slideshow? No? Oh, okay, well, let's try again. Sorry, you guys should have said something sooner. But I guess if you were all seeing the same thing, you didn't know what you weren't seeing. Okay, let me see. Let's try again. Okay, can you see that now? Okay, well, sorry. Do you want me to go back to those slides? Okay, you can reference them with the PowerPoint in week 1, okay? So for your attendance, you have to be here in class for the entire time. If you're 1 minute late, you miss 15 minutes of attendance, okay? Goes in 15-minute increments. So if you're 16 minutes late, you're gonna get counted as 30 minutes absent, okay? Assignments open the week that they're due. So they start at 12 a.m. on Mondays, Pacific time, they'll open up, okay? And then they're due by 11:59 Pacific time on Sundays. Now, if you have a discussion post, your initial post is due Wednesday by 11:59 Pacific time, okay? And then you have to reply to at least 2 other classmates by 11:59 on Sunday, Pacific time, okay? Other assignments are due by Sundays at 11:59 p.m., okay? Your live session is in Eastern time, okay? So make sure you know what time zone so you're on time, you're not getting thrown off by your time zones, okay? And we're always on Mondays if you stay in my section. You know, a lot of times there can be a lot of moving around during the first couple weeks. So if you stay in Professor Becker, Dr. Becker's section, then it will always be on Mondays starting at 2 p.m. Eastern. Okay. Academic integrity, obviously there's no cheating, there's plagiarism. You can get in trouble, you can fail the class, you can be kicked out of the program depending on how severe it is. Also, using notes or materials during your exam, that also will could potentially result in being kicked out of the course. Okay. Altering or, plagiarizing someone else's work and not giving them credit, allowing others to copy off of you or use your work, AI kind of papers. Right now, I mean, all of that we can still figure out if it's AI. Okay. Giving others the answers. So, you guys are early quiz takers. If you go in and give other sections the answers, that's also considered, lack of academic integrity. Our code of ethics for nurses, we go off of the American Nurses Association Code of Ethics. So their statement is of ethical values, obligations, duties, professional ideas of nurses individually and collectively, okay? It's not the profession's non-negotiable standards, okay? But it's an expression of the nurse's own understanding of their commitment to society. And then if you want to read the Code of Ethics for Nurses further, you can go to that website. Okay. These sites, so like I talked about AI, Course Hero, Stuvia, there's a few of them out there. They're all being monitored by some Fortis faculty, okay? So if we see anything out there on these websites, then you're potentially at risk for having a violation of academic integrity. So don't be going on these websites or putting anything on these websites. Okay. Okay. We kind of already talked about this. You have to be logged in and logged out. So that will be based on the time that in Zoom it says you guys log on and log out. Okay, that's how I'll do my attendance. Like I said, it's done in 15-minute increments. So if you are 1 minute late, you're 15 minutes late. So make sure you're here before 2 o'clock Eastern. Okay. You need to log in with your name that Fortis has you identified on. Okay. Otherwise, you'll be counted as absence. Okay. That's how we make sure you stay here and you're here for class. If your camera's not on and you're not on camera, then we'll deduct time from your attendance. Obviously, if you're running to the bathroom or something, that's a little bit different. Make sure your face is in the camera for attendance while you're on camera, okay? Okay. So I kind of already talked about this. If you miss 1 minute, you'll be deducted 15 minutes. Anyone who doesn't get to attendance or isn't counted for attendance for 14 days in a row, 2 weeks, 2 classes you missed, then you'll be dropped without any notification of myself or yourself until you try to log back in. Okay. You'll be dropped, no questions asked. Okay. And unfortunately, there's nothing that we can usually do about that. Okay. If you missed attendance, there's no way to make up your attendance. Now, if you miss for some reason and you let me know what was going on, then, and you miss a quiz or something like that, and you had, you were really sick and you had to go to the emergency room or your kiddo did, and you have proof of that, then we can talk to Dr. Brown on, if you can do that quiz or something that you missed. But I need to be told prior to class starting. Let's see, this is kind of all the same stuff. Chronic absenteeism. So in the excess of 20% of missing scheduled hours, you may receive a failing grade or a grade deduction at the end of the course. Okay. So make sure you guys are here. Late work policy, you have 1 week after something is due with prior approval from myself. So if you are going to be late, turning something in late, you need to let me know before the due date that you're going to be turning it in late. Okay. 1 to 7 days is a 10% automatic deduction. 8 or more days, there will be no, you won't be able to turn that in at all. It will be an automatic 0. Cameras should be on at all times. If you are in a vehicle, you're riding in the vehicle, you're driving, you cannot be in class either way. It's a safety issue for you guys. So you will be asked to remove yourself from class. And if you do not do that, then I will remove you. You need to treat this online class as if you are in or on campus. Okay. Okay, stay in contact with me. That's the biggest key to success. Make sure you have a reliable internet connection, a laptop, a computer. You will also need a second device for exams. So you will have your laptop or computer that you'll be taking your exam on, and then you also need to utilize your cell phone as your Zoom camera during those exams. Read all of your assignment directions carefully. If you have questions, ask me. Make sure you are in a quiet, distraction-free place to complete your schoolwork and also to do your exams and quizzes. You must log in 4 to 5 times a week to continue to stay connected and engaged. And you can do that pretty easily by, doing your discussion posts, doing your replies, and, viewing all of your assignments that are due for that week. The best thing I can tell you to do is do not procrastinate, because the longer you procrastinate, the, more likely it is that you will be stressed out, and you might not do as well on your assignments. Okay, day 1. So today is day 1. Make sure you logged into Canvas. Make sure you have your book downloaded, okay, and you can get into your ebook. I know those of you had reached out to me that the link to purchase the actual paperback book was not working. Hopefully now it's working for you. And if it's not, then just let me know and I can send you the direct link to purchase the paperback book. Okay, print or save the course syllabus, use the syllabus along with the modules each week to make sure you are on the right track. Okay, now my students last term asked me to post the following week's material on Thursdays. So I will be posting that at midnight on Friday morning. Okay, for the next week material, as long as that's not going to confuse you all. Do you feel like that would be confusing for you for me to do that? No, you guys will do okay? Okay. All right, so I just know that my last section had said, that they try to do a lot of their work over the weekend if they can. So for the following class, and with you guys being Monday class, I know it's hard to kind of get your reading material first completed prior to class without doing that. So any issues with textbooks? You've been able to get onto your ebook, you've read the material for today. Yes, you're able to get on your ebook. Okay. Okay. And make sure you're looking at the syllabus. Okay. Come to class prepared. We will discuss the concepts. Okay. Make sure you're checking your Canvas to-do list. Okay. Your calendar and all of that. That'll help keep you organized. You can meet with me. We can set up a time to meet if you're having difficulty with different concepts. Or if you take the first exam and you're having, you're not sure what you missed material-wise, we can go over concepts. Okay. Technical difficulties, contact IT, or you can let me try to help you with what I can. Okay. So weekly review sessions, I do not necessarily do tutoring unless you guys reach out to me, but we can figure out an appointment time. Mondays are the only days that I don't work other than the weekend at my other job. So Mondays are usually the day that we can set up some time. Okay. Oh, I think someone came off of mute. Do you have a question? No. Okay. I just wanted to make sure. But each week prior to the exam, all of us instructors will do exam reviews. Okay. And we will record those. It is better if you can attend live because you can ask that professor questions live. Students who do that do a lot better on exams. It's just, that's how it is. We will post all of the recordings from the other instructors at review sessions though. Okay. And like I said, that's the week before exams that will happen. Okay. 80% of your grade is KGA material. So that's your exams, your quizzes, and your HESI. Okay. So that's 80% of your grade. And 20% is your discussion questions, dosage calculations. It says CJ Sims, but we're doing SharePoint this year. Case studies, so a little different than CJ Sims. NCLEX questions, your clinical assessment paper, which that's your big, huge project that's due week 8, and then your HESI practice, PEDS practice exam, and your assignment practice exam, okay? So this is how your grade breaks down, okay? Your discussion questions are pass fail, okay? Your weekly attendance is pass fail. It depends on how long you are here, okay? Weeks 1 through 5, your homework grade will be shut off so you can see what your KGA grade is specifically. In order to pass, you have to have a 78% KGA average before I will turn on your homework grade, okay, at the end. Week 6, I turn on the homework grades. Those stay on until week 8, okay? This kind of lets you guys know where you're sitting with your KGA, and then with homework grades added back on, before, you know, it's time to potentially drop the course, okay? And then after week 8, I shut them off, the homework grades off again, and you can see where you need to be going into the HESI. Any questions about grading? Like I said, your combined scores for your KGA material, so quizzes, exams, and your HESI has to be a 78% or higher before homework grades are given credit. Okay. You also have to pass your clinical and simulation portion of the course. Okay. And like I said, if you are struggling attendance-wise throughout the course at the end of the term, then that can be a factor to whether or not you pass as well. Okay, quizzes will be given at the beginning of class. It's going to be on the week before material, okay? Once you start the quiz, you will not be able to pause it or restart it, okay? They are 15 minutes. Now, if you have accommodations, I need to see your official accommodation letter. You need to send that to myself and also Dr. Darlene Brown. Okay. So if you have that, I need that this week. Okay. So that way we can get you all set up. I can make sure you have enough time on quizzes and your exams. Deal? Okay. Exams, those will be given through ExamSoft. You have to log in through ExamSoft on your Canvas. Okay. And then, like I said, you have to have 2 separate devices. One will be on Zoom for your camera, and the other you will be taking your exam. If you start having any issues during your exam, last term I had calculators not work for some people. They were giving them fractions. I'm not sure why that happened, but there were a bunch of issues 1 week on ExamSoft. So if anything starts not working for you, you need to chat me right away during that time. Okay. Sorry, I'm reading a question here. There won't be 2 questions for material in the upcoming week. So week 1 quiz, or the first quiz will be over this week's material, as in the PEDS material that we cover, okay? We won't have quiz over week 2 material until the following week, okay? So it's always the week prior material that you're gonna have that quiz on. Does that make sense? Okay. Your exams, you have 75 minutes unless you have accommodations. You need to make sure you're paying attention to your time. Just like with the quizzes, once you start, you cannot stop, pause, or resume. Okay. But you have plenty of time on those exams usually, so make sure you're taking your time reading, the questions multiple times. Okay. When you're done with your exam on ExamSoft, you'll click Save and Upload, and then you'll have to show me your confirmation green screen, and then you can log out of your testing. We'll talk about this again before exam 1. Okay, so making sure you're compatible with ExamSoft. If you have a Mac, you have to use the Sequoia operating system. Okay, so make sure your computer is up to date. Make sure your ExamSoft is up to date. If you have any issues, then we need to talk to IT. Okay. Okay, someone's asking about exam campus proctors. If you can find an approved proctor on exam and they're on the approved list for that campus, then yes, you can do that. You have to let me know 72 hours in advance. Okay. Anyone with accommodations, like I said, you need to let me know this week. Okay. 10 days or less of notification prior to an exam, we will not be able to allow you to do accommodations. And then here's the exams can be proctored by an approved faculty member on campus, but I have to get 72 hours notice. And honestly, the sooner you let me know, the better. And what works best for me for if you're going to be testing on campus is you CC me and that, so you email not only myself, but also the faculty who's going to be doing the proctoring on campus for you. Okay. So they can let me know, yes, they have approved you doing that with them. And I have their contact information. Okay. Any questions about that? Okay. Exams will only be held during our scheduled class time. Now, if you have written approval from myself and Dr. Darlene Brown, so the National Dean of the online program, then you may take an exam at a different time period. Okay. So when you're doing online proctoring, or excuse me, on campus proctoring, that proctoring needs to happen during class time. Okay. Any questions about online proctoring stuff or on campus proctoring stuff? No? Okay. Otherwise, if you're not on campus proctored, then your exams will be proctored via Zoom. You have to stay on camera at the entire time. No earbuds, no headphones, no smartwatches, no papers. Okay. You have to have whiteboards, no calculators. You will use the calculator on the exam. Okay. And I have to see a photo ID, whether that's your driver's license or your Fortis ID. Okay. And then, of course, if you have some sort of religious exemption, you need to talk about this with myself and prior to that happening for an exam check-in. Okay. So missed exams, you have to let me know beforehand what's going on. Okay. If it's an emergency, then you can notify myself and Dr. Brown within 24 hours of the scheduled exam, ideally prior to the exam being taken, but obviously in an emergent situation that might not be possible. So you need to let us know within 24 hours. If there's nothing, no notification, then it's a 0 on your exam. Okay. And then if we approve that you can take the exam late, it has to be done within 7 days, just like all the late work policy. Get a hold of me. This is the the biggest thing is if there's something going on preventing you from being successful on the exam that's happening before the exam, or you were having issues with your exam or any of that, I want you to be successful, but you guys have to communicate and let me know. So if there's personal things going on with you, I'm not going to broadcast that clearly to everyone, but you need to let me know what's going on because I can only help you if you communicate with me. Okay. If you have more than one exam on the same day, you're still expected to test on that scheduled day with me. Okay. If for some reason you're testing on another day because you got that approval from myself and Dr. Brown, then you'll be taking a different version of this test. Same if you're proctored on campus. Any questions on the quizzes or exam material stuff? No? Okay, we'll go on to the homework. Okay, so reviewing your syllabus. You should look at this every week. You should look through your modules and make sure it's lining up with your syllabus. If you have any questions about the module material or your syllabus, let me know. Okay? Schedule out a calendar. You have the calendar through Canvas, but also it helps for you to write out each week so you know what's due each week and you don't have to try to guess or go off of memory. Okay. Make sure you complete all of your required readings prior to class starting. Okay. And then follow rubrics. That is how I will be grading you. That is how you're successful in this course. Okay. So this is just clearly a way that you can pull from your syllabus and write it out on a calendar. NCLEX questions. So this is from your Sanders Comprehensive Review for the NCLEX RN exam prep, okay? So these are questions similar to what you will see on the actual NCLEX, okay? So your instructions are that there's some instructions like this through within the module. When you click on this assignment, it will walk you through exactly what you need to do. If you have any questions, you can go back to this PowerPoint to be walked through step by step to make sure you're getting the correct NCLEX review questions. Okay. Most of them will be PED specific. However, there are a couple weeks that are under growth and development instead of pediatrics. So make sure you're clicking the correct 50 questions sections. Okay. The first week you will have NCLEX questions will be week 3. And this is where your information is from the developmental stages instead of pediatrics. Okay. So you'll go to the developmental stages and then you'll have to pull the infant, preschool, school age, toddler material. Okay. And adolescent. Okay. And your NCLEX questions cannot be a screenshot. They have to be saved as PDF for that to be able to open for me. So this is how you can save it as a PDF. Grading of NCLEX questions. You have to do 50 questions. I will grade it out of 50, whatever you get right. Okay. You can repeat the questions as many times as you want, but the first submission of your grade is what you'll get. Okay. So once you submit it, that's what you're receiving. Okay. So if you get 40 out of 50 correct, you get an 80%. There are no bonus points for getting more than 50 questions correct. Some of my students like to do more than 50 questions, but that doesn't change your grade. It's still out of 50 questions. Okay. Okay, case studies. So these will support the development and application of your knowledge to be able to take your boards, your NCLEX, and your HESI. Okay. There are 5 case studies. They are week 5 through week 10. Okay. So here's the schedule. These case studies are found within your weekly modules. Okay. So the case-based sim chart case studies, these are what we are doing instead of CJ Sims. Okay, you will have to log on through Elsevier, through SharePoint. Okay. There's a quiz that aligns with the content of the case study. Okay. So, like I said, this is what you'll see. Sim chart, respiratory dysfunction. This is under week 5. Okay, so this is how it will look. You will click on that. It will pull you into sim chart. Okay. It will look like this. You'll start your case study. You'll have a little synopsis. So the week 5 is a little kiddo with RSV. Okay. And you'll have multiple sections to complete. You'll have to complete one section to unlock the next section. Okay. Okay, your pediatric assignment exam and your pediatric practice exams. These are 2 separate assignments. They are in Elsevier. Okay, but you have to go in through the course to do that. If you are repeating the course, I have to reset your previous work. So you need to let me know if you're a repeat. Okay. If you're not logging in through Canvas into your Evolve account, then I will not be able to see your grade. So make sure you're logging in through Canvas into Evolve. Okay, through the link within the module. Okay, here's how to do that. Your first attempt will be what is recorded. Writing your papers and discussion posts, make sure that they are professional. You're going to have a 3-part assignment, your pediatric clinical assessment. This is what I was talking about at the beginning. It's not due until week 8. However, you need to let me know the topic prior to turning it in. So if for some reason you don't let me know what diagnosis you're picking and you submit it, then, you know, we'll have to have a conversation about that because I had not approved it. Okay. So this clinical assessment assignment is an APA paper. Okay, so it's in APA format. You're going to make a teaching tool for your patient or either family or whatever category of audience you pick for your teaching tool based on your diagnosis, and then you're going to do an assessment of that patient. Your assessment needs to mimic what a patient with that diagnosis you picked would look like. So if you pick someone with asthma, in your assessment on your breath sounds, they need to have expiratory wheezing. Does that make sense? And your paper, if you go off of the rubric, that will tell you exactly what you need in the paper. You're going to talk about pathophysiology. You're going to talk about how your pathophys and all of that connects to your specific patient. Okay. And like I said, follow the rubric. This is how you'll be successful. Purdue OWL is really helpful for APA 7th edition format. So that is usually where I direct you guys to go. If you turn in your assignment early, then I will do a quick review of it and give you feedback, and you can make those changes. I will let you know that week how early you turn it in where I can continue to do that. Okay. Usually if you turn it in by the Thursday before it's due, then I will give you feedback on it. And then you have time to make changes and then turn in a new updated version. You cannot use resources if they're more than 5 years old because it's very likely that that material will be out of date. Okay. Cite your sources. So anything that is not your own original thought or words or common knowledge needs to be cited. Okay. Discussion questions. I also would like for you to cite material there too, at least in your initial post. Okay, this is getting sort of repetitive. Nursing quizzes and exams both are timed. You have to complete them one time. If you start and it starts not working for you, you let me know and I will, do what I can to help you. So if your computer's not working, if there's something going on ExamSoft and it's not working correctly, make sure you're letting me know. You stop and let me know right away. Okay. You can text me, you can call me. If we're in an exam, send me chats. That will be the best way during exams to get a hold of me. Okay. And if there's something going on, obviously email is another option. Okay. We won't just automatically allow there to be an exam retake because of technical problems if there's if we wind up figuring it out. Okay. Obviously that's going to be stressful for you if you're having all these technical issues right before an exam. But if we figure it out and you're able to still take the exam, we expect you to still take the exam. Okay. HESI exam, these will be on campus. The scheduled timing will vary based on your campus. Okay. One attempt of the HESI for pediatrics, you'll have assigned date and a time for the exam. Usually if your campus offers a date on a Monday around the same class time, that is going to be the section for the HESI that you sign up for. Your goal is to get at least a 900. Okay, you will have remediation based off whatever your HESI score is, and that has to be submitted by midnight the week of week 12. If you do not submit and complete your HESI remediation, you'll get a 0. And then here is this. This will be posted under the week 11 announcement for reference. It will also be under week 12. Week 11, you will not have a lecture course. Okay, so we won't meet for class week 11 because you'll be taking your HESI and that will be your attendance for that week. Week 12, we will meet for about 30 minutes and go over the most common missed HESI topics. Exam security, we already talked about this. Your camera has to be on. You have to be full face present at all times. If you don't show me your school ID or photo ID, then, or you're not visible on camera, then you'll fail the exam and potentially fail the course. Okay. Okay, so I wish you luck. This term, we'll go ahead and stop with this PowerPoint. It's kind of a lot of repetitive things, but we have to go over it every term, okay? Okay. Do we want to do PowerPoint first and then potentially the Kahoots, or do we want to start with Kahoots and then PowerPoint? Totally up to you guys. You can unmute and just let me know what you'd like to do.
PowerPoint.
Okay.
Yeah, PowerPoint.
PowerPoint first? Okay. That is fine with me. Okay. Okay, I'm going to share my screen again here. Hopefully you guys will be able to see it. Okay. Okay, can you guys see my screen? Yeah? Okay. Cool. Okay, so chapter 26 is the first topic. So healthy kids 2030 and bright futures are kind of what got along with the AAP, the American Academy of Pediatrics is who comes up with Healthy Kids 2030 and Bright Future Goals. So this is what pediatric nursing is going to be focused on until 2030 when they meet again and review for then 2040. Okay, so they are focused for this 10-year period from 2020, which it kind of got a little delayed in 2020 because of the pandemic, to 2030. So oral health, healthy sexual development and sexual activity, physical health, as far as increasing physical activity, healthy weight, nutrition, mental health goals, family support, supporting development of the kiddos, safety and injury prevention, and community relationships and resources. So these are kind of the top things that are focused on for pediatric nursing. The big specific health problems are obesity and type 2 diabetes, childhood injuries, violence, vaping epidemic. I'm sure a lot of you guys have seen kids or had your own kids vaping or heard of kids vaping. This is a huge problem, as well as the continued mental health crises. Infant mortality is still a huge thing for the United States. The number of deaths per 1,000 live births during the first year is kind of what you look at for infant mortality. Neonatal mortality is considered less than 28 days of life, and then postnatal mortality is 28 days to 11 months. So the United States continues to lag or continues to have higher numbers of infant mortality than other nations. Okay. Birth weight is probably the most common determinant of neonatal death. So if kids are low birth weight, so less than 5.5 pounds, they're at an increased risk for infant mortality automatically. Death rates in children greater than 1 year of age are less than that for infants. Okay. Children ages 5 to 14 have the lowest death rate. Okay. And there has been an increase, a drastic increase in injuries, homicide, and suicide in the adolescent groups for childhood mortality. Okay. Childhood mortality. So what places kids at increased risk of morbidity, or I said childhood mortality, I meant childhood morbidity. So there are specific groups or risk factors that place kids at increased risk for morbidity or illness. Okay. Homelessness, being impoverished, so living in poverty, low birth weights, having chronic illnesses, things like asthma, foreign-born adopted children are more at risk, and kids in daycare centers. So these are all risk factors for increased chance of illness or morbidity. Now, mortality is death. Okay. The art of pediatric nursing. So we follow the American Nurses Association philosophy for care. So pediatric nursing is family-centered care. The family is the constant in the child's life. So making sure that they have support, respect, encourage involvement, and then enhance strength and competence of the family members. Yes, I record the lecture. And I will post it. I forgot to tell you guys this. I have a YouTube channel, which is in that first announcement. If you guys subscribe to that YouTube channel, that's where I post my material from each week's recording. I will also post an announcement that just simply says week 1 recording, week 2 recording, with the link to that YouTube video. Okay. Okay, back to the art of pediatric nursing. The needs of all family members must be addressed when caring for these kiddos as well. Okay. Concepts of enabling and empowering these patients and their family in their care. Okay. Atraumatic care is your goal for pediatric nursing. You don't want to make that child more traumatized than they already are with being in the hospital setting. So therapeutic care, try to group your, cluster care as much as you can. Getting that kiddo involved in their care, utilizing play. If it's a younger kiddo, a preschool kiddo, using play is really helpful in getting kids involved in their care. The setting of where the child's being cared for is also important. So if these kids are in a hospital room, if you are able to take them to, so the hospital I used to work for as a pediatric nurse, we had what we called a procedure room. Well, anything bad, so pokes, blood draws, IV starts, shots, any of that would happen in that procedure room, because we wanted those kiddos their room that they're staying in to feel safe to them, and for them to know that there's not going to be any physiologic distress happening in that room. Okay. You want to also reduce physiologic distress and physical distress. And obviously your goal in nursing across the board is to first do no harm to those kiddos. You're going to build a therapeutic relationship, not only with that patient, but also with their family. You're going to work with the family, the parents, to advocate and to care for that child and empower them in knowing that when they go home from the hospital setting, they'll be able to provide the best care for their kiddo as well. Obviously, disease prevention and promoting health in nursing across the board is the goal. Teaching on health and injury prevention is also important. Depending on your setting as a pediatric nurse, if you're in a school setting, you're going to do a lot more, education on safe sex and health kind of topics, versus, if you're in a hospital setting, that might not be so much your goal or your role. Support and counseling that patient, that family. You're going to coordinate and collaborate with the others on your team in caring for that kiddo. So the residents, the physicians, nurse practitioners, specialists, all of that, you will be kind of the eyes and ears for all of those specialties. Okay. You're going to be focused on making ethical decisions. Some pediatric nurses go into the research piece, and then obviously staying up to date on evidence-based practice changes is also a very important part of pediatric nursing. Okay, here's your question. What's the leading cause of death among African American boys ages 15 to 19? And you can just shout it out. C? Yes, that's correct. Okay. So chapter 27, this is family, social, cultural, and religious influences on the child's care. So the definition of a family, the definition of a family is whatever that child says that the family is. So family dynamics can look different, right? So a phenol is a marital relationship, so parents are married. The family of origin, so that's the family that that child is born into. Okay, but as that child grows, that family of origin, maybe the original family, the parents divorce, and then they, both marry new partners. Well, then that family role, kind of that dynamic changes. Okay, so the family is whatever the patient feels should be involved. So there's a traditional nuclear family, which is mom, dad, and kiddo. There's the blended family, which is what I talked about, parents separated and now they're, they both have kids from previous relationships. They all live together. Single parent homes, there's binuclear homes, there's polygamous homes, communal homes. So, a bunch of different families all live together in a community, and then LGBTQ families. Okay, so this is there's a variety of different family structures that you'll be working with, as well as cultural involvement. So just being aware of your patient specific family scenario. Okay, you can use the strength of your own strengths and also the family strengths to kind of meet those needs and to guide your teaching. Okay, so you'll have to be aware of kind of the roles. Do parents have traditional roles, or is it a single family home where the mom or the dad is doing all of the things for the kiddo, plus still having to work? So you'll have to work with the family and teaching them on how best it is to care for their child. Okay, different parenting styles. There's kind of the laissez-faire parenting, so the kids kind of do their own thing. There's the authoritarian parenting style, so the kids have really strict rules and a really strict schedule. And then there's the parents who are kind of in between. So you'll have to assess kind of their parenting style by observing that parent with the kiddo while they're in your care. Making sure that they're setting limits, disciplining, figuring all of that out by talking to the parents. Okay. Are they using corporal punishment like spanking? So figuring all of that out. Parenting the adopted child, this can look a little bit different. There can be differences in culture. If they adopted an international child. So working with parents on these situations as well and just being aware. Okay. Divorce can really impact children. Sometimes it's beneficial, sometimes it's not as beneficial. There can be single mothers, there can be single fathers, working mothers, some moms stay at home, some dads stay at home, some dads work. Fostering kids. Do parents who have gone through a divorce, what does their custody agreement look like? Do they both have rights to make decisions medically, or does one parent have more of a right than the other to make that child's decisions for their health? So just kind of being aware of all of these different family dynamics that can go on. Social cultural influences on the child and family. Obviously, we don't expect you all, and I don't expect myself to be totally aware of everyone's culture and social influences and their religious influences. So the biggest thing would be to ask questions, to admit, wow, I'm not so aware of this specific cultural background. So can you let me know on how I can be helpful to you, or what I can do to kind of direct your care in a more respectful, personal way. And these influences specifically based on the kid's environment. So, peer cultures can affect their development. Social media, mass media, so the news media, That can definitely drive their societal kind of awareness, race, ethnicity, poverty level, parental education. So you have to kind of be aware of all of these things and how it's going to influence your care for that kiddo. Okay. A frequent health problem of migrant children and adolescents in the United States is, which question or which answer is correct?
C.
Tuberculosis. Yes. In migrant children, a common health problem is tuberculosis. Okay. So by knowing, migrant children are more, apt to have these types of diagnoses, that can kind of help gear your care as a pediatric nurse. Okay, chapter 28, developmental and genetic influences on child health promotion. So your foundations of growth development. So growth is going to be how that child physically grows. So height, weight, numerical numbers. Development is going to be more on, kind of a range. Okay. Maturation is how they mature. So think of adolescent boys versus adolescent girls. Girls are typically more mature mentally than boys. Boys, it usually takes longer to catch up. So that's maturation. Okay. All of these things can kind of go on a varying kind of scale. So not everybody crawls at this exact moment. Some kids sit and then skip crawling and start walking. So there's kind of a difference in growth and development, but just to kind of know the foundations and the basics of growth and development is going to help you be successful in this course. So developmental tests, this is kind of what I talked about, directional trends. So step-based trend, most kids follow. So sequential trend is where they crawl before they creep, which means they walk along something, they creep before they walk by themselves. Okay, but not all kids do a sequential trend. They might skip some steps. Developmental pace is the same as developmental milestones. So if you see developmental pace, that means the same as meeting their developmental milestones. There are very sensitive periods, from infancy to 2 or to 3 years of age. Look at how much growth happens developmentally. They go from, laying flat on their back nonstop, not really doing anything other than sleeping, eating, peeing, pooping, to sitting up by themselves, eating purees and table foods at 6 months of age. So there's huge growth and development. And then, from 6 months to 2 years, then they're speaking sentences. So, and walking all around. So there's a huge period of growth during early infancy. So newborn period through age 3. Okay. Like I said, there's going to be some variation on all of these developmental tasks. Okay. So in the infant, thermal regulation, so they're working really hard to regulate their temperature. They're working on also their metabolism. So working on nutrients to be able to grow appropriately, and they need sleep and rest, because of the huge growth and development that happens from infancy to age 3. Okay. And based on these kids and their individual characteristics, you have to kind of know that kiddo's temperament. Are they an easy child? So they're pretty go with the flow kiddo, or are they a difficult child? So, they're just really fussy and everything you do doesn't seem right, and they're more complicated to manage and to care for. Or is it a kiddo who's slow to warm up? So that's kind of like the kiddo that's going to keep their eyes locked on you and watch you and not talk to you or interact with you until they've met you, a few times, or maybe you start playing kind of with them to try to get you, them to allow you to do your assessment. That would be a slow to warm up child. So their temperaments definitely affect what you can do from your nursing perspective, okay, in caring for these kids. And then obviously the environment that they're growing up in, the family dynamic that they're growing up in, their culture, all of that affects, kind of stepping stones for their growth and development. Okay, so like I said, your theorist will be a huge part of something this term that you just have to memorize. Okay, so your psychosexual developmental theorist is Freud. Okay, now birth to 1 year is the oral stage. Think about what kids are doing, their first year of age. They're eating mostly, right? They use their mouth to eat. They are crying to eat. So oral stage, think birth. Anal stage, 1 to 3 years. What's happening during the anal stage? Potty training development, okay? 3 to 6 years, that's when they're phallic stage. So that's when they're more potty trained. They're maybe starting to notice, or you'll get questions as parents or as nurses, boys and girls differences, okay? Latency stage, this is school age group, 6 to 12 years of age. This is just prior to puberty, typically. So the latency stage. And then general stage, this is during the puberty phase, so 12 and up. Okay. Psychosocial developmental theorist, this is Erickson. This is trust versus mistrust, which is birth to 1 year, autonomy versus shame and doubt, 1 to 3 years of age. We will go into all of these more specific, so I'm just reading them off to you right now. Initiative versus guilt is your, preschool, school age kiddos. Industry versus inferiority is later school age. And then identity versus role confusion are your adolescents. Okay, cognitive developmental theorist is Piaget. Sensory motor is birth to 2 years. Pre-operational is 2 to 7. Concrete operations is 7 to 11, and formal operations is 11 to 15. Okay, language development. So we are all born with the mechanism and the capacity to develop speech and language skills. Now, our environmental, how we're growing up, our family dynamic, are our parents impoverished? Are we struggling to make ends meet? Are we, not able to have our basic needs met? This can all, our parents, have lower education skills, they struggle with speech development and language skills themselves. Are we learning a second language? Are we Spanish speaking or, speaking another language and English is our second language? That all kind of factors into speech development and language skills. But when we are born, we have the basic capacity and mechanisms typically to develop speech and language. Okay. As long as we have the intact physiological structures, so as long as our hearing is developing appropriately and all of our, our throat and our larynx and all of that has developed anatomically appropriately, then we have that ability. Okay. Okay. Moral development is Kohlberg. Okay. So this is pre-conventional, conventional, post-conventional. Okay. So play is a huge part of development in kids, especially young kids. So looking at the different types of play, is it skilled play? Is it just dramatic or pretend play? Are they playing games? Are they doing sensory play? So, they're using those, I hate these things, the orbs, because I've seen kids swallow them and have a lot of issues. But, those orby things that kids like to play with, those little squishy kind of gel ball things, that would be a sensory play. Or making like a little tornado kind of thing in a water bottle with glitter and glue and all of that. That's kind of another sensory play. Skill play is your playing to accomplish a skill. So those little like puzzles that you can do. So the kiddo is putting the puzzle together to accomplish a skill. Okay. Dramatic pretend play, that kind of speaks for itself. They're pretending to be, a nurse like you. That's one good way to get them to allow you to do their assessment too. Or are they playing actual games? Okay. Toys help with sensory motor development. They help with intellectual development, socialization, creativity, morality, therapeutic value, and also self-awareness. So playing with toys are a huge developmental importance for growth and development, kind of a stepping stone. Okay. So if kids aren't having a lot of play, then, they're more likely to have growth and developmental delay. Okay. Onlooker play. So this is a kiddo watching another kiddo play. Okay. And they're just kind of watching that other kiddo play. They're not playing themselves. They're not interacting. Okay. Solitary play is playing all by yourself. They're not paying attention to anyone else. They're just playing by themselves. Parallel play is you're both playing, two kids are playing next to each other. They're not interacting with each other. They're not playing, the same task with each other. Okay. Associative play is you're playing the same sort of game, but you both have different goals in mind. So one wants to play this way and the other wants to play the game this way. Does that make sense? And cooperative play is you're playing, a game and you both have the same goal in mind, or you're building a castle with Legos and you both want the castle to look the exact same. Okay. Toys can support and enhance childhood development. They bring the opportunity of drawing those kids in and involving the parents in their play as well, pushing, pulling, rolling, manipulating, anything to develop those big muscle groups and the small muscle groups. So coloring, drawing, even if it's not real neat and organized, painting, all of that sort of thing is really great for childhood development as well as reading. Okay, developmental assessment. So there are different screening tools that are utilized at different child visits usually. Okay. So if you are a pediatric clinic nurse, you likely will do ages and stages, which are questionnaires that parents fill out at certain age groups that talk about some of the basic things that these kids should be doing at that age group. And if they're not doing it, then depending on how many things they're not doing, then that kind of tells you that they're at risk for developmental delay, or they're in that category where they are having a developmental delay. Okay. Your objective measurements are going to be your growth. Okay. Height, weight, vital signs. Okay. The other thing that is done developmentally are screeners like MCHATs, which look for autism screeners. You assess kids with disabilities at some of these checkups. Okay. Okay. So genetic factors that influence development. So your genes are what's actually expressed, right? So your specific genes in your genome that are expressed. Genetics is, the inheritance pattern from your parents. Okay. You can have congenital anomalies, which are defects or disruptions or dysplasias or malformations that are inherited from your parents in utero. Okay. So congenital anomalies are things that kids are born with. Defects such as clubfoot, or congenital amputations, which would be a disruption of the genetic material. Okay. Dysplasia, which would be abnormalities of hair, teeth, sweat glands, nails, or malformations like cleft lip. Okay. So based off the intrauterine environment that places you at more, if there's a infection or, parents are smoking, there's a toxin that these kids are being introduced to, then, that places them at risk for things like Down syndrome, Prader-Willi, Turner. Those are all genetic conditions, but based on intrauterine environment, these kids may have developmental delays based on whatever they were exposed to in utero. Okay. Your role as a nurse in pediatrics in the genetics piece are doing your nursing assessment, so your physical assessment, identifying those delays and referring these kids with your provider, and then supporting the parents, educating them, and caring for them. Okay, chapter 29, communication and physical assessment of the child and family. Okay, communication. So making sure it's age appropriate and appropriate level for also the parents. Okay. HIPAA is still a factor, even though it's kiddos. Okay. There are only special cases like pregnancy, mental health things that are privacy protected from parents. Okay. Or confidential specific from parents. Okay. Triage and counseling. This may also be something that you're doing, or will be something that you're doing as a nurse often. Okay. Communicating with the parents, making sure that you're encouraging those parents to express their concerns or ask questions, listening and being aware of cultural or religious needs, being empathetic, providing anticipatory guidance based off of that kiddo's diagnosis, or allowing them to kind of show you what you've taught them in caring for their kiddo. And obviously, if there's a communication barrier, then due to a language discrepancy, then you need to utilize an interpreter. Okay. Communicating specifically with the child to make sure their developmental period that they're in, and how that will affect how you communicate and care for them. Okay. Okay. So you as nurses, one of the first things you're going to do with a patient is you're going to be taking their medical history. So you want to identify who is giving you the information, which is usually the parent. That's going to be your informant. Okay. You are going to figure out what their chief complaint is. So that means, what are they here for today? What brought them in to your clinic or your hospital or wherever you are as a nurse? What brought them into your office at the school? Okay. You also need to figure out what's going on with their present illness. So say their chief complaint is, ear pain. Okay. Well, a week ago they had a cold, they were coughing, they were snotty, they had a fever, and now they're having ear pain. Okay. So this is figuring out what signs and symptoms they're having and what symptoms they're not having and how long they've had them. And, did they try Tylenol? Did they try honey for their cough or over-the-counter cough medicine, which is typically never recommended in pediatrics. But, some people do give their kiddos cough medicine. So figuring out kind of what's bringing them in, what's been going on with them. Also, deeper looking into history taking, you're going to want their birth history. So were they full term? Were they premature? Did mom smoke throughout pregnancy? Did she use drugs? Were they exposed to, did they have STD or an STI while they were pregnant? Any of those sort of things. Complications with delivery, complications after delivery, gestational diabetes, all of that. You also want to look at their dietary history. So what sort of things do they eat? Are they still eating the same kind of groups of food or the same amount as often as they usually do, or has that changed? Have they had previous illnesses, injuries, surgeries, medications, allergies? Are they up to date on their vaccines? What are they doing for growth and development tasks, and what some of their habits are? Okay. In adolescence, okay, or late childhood, it's appropriate to do sexual health history. Okay. So are they sexually active? Do they have regular cycles? Do they have a lot of cramping with their cycles? Do they have questions about their orientation? All of that is involved in a health history as well. Family medical history, and knowing, where they've lived and grown up, because knowing their geographic location, like we talked about earlier, that can potentially put you, on higher alert for things like tuberculosis or other, Lyme, things like that, that might be more prevalent in other locations that these kids have lived. Okay. Also looking at their family structure, who's involved in that, what does that look like, kind of what their home environment is. Okay. Psychosocial history. So what is this kiddo's temperament? How have they adjusted to school or daycare? Do they have any unusual habits? Kind of what that parent-child interaction looks like. And then the review of systems. So this is specific for each body system. So if you have a kiddo that had cough congestion, okay, for their respiratory cough, are they having shortness of breath? So you kind of just check box through every body system. So are they having any issues with their ears? Yes, they're pulling on their ears. Do they have nasal congestion? Yes. Do they have decreased urination because they're not drinking as well, because their throat hurts? All of that sort of thing is kind of what you're looking at with your review of systems. Okay. Dietary intake. So this is what they typically eat. Are there any cultural differences in food intake for these kids? Looking at their nutritional assessment. Are they malnourished? Are they at risk for being malnourished? Are they well nourished? Are they over weight or obese? So kind of looking into all of that during your health history. Okay, once you're done with your health history, you get all the information first from the parents, okay? Or the family and that patient if they're older. And then you progress to your physical assessment. Okay. In your adult population, you did head to toe, head to toe, head to toe. That's what you have all heard for your adult nursing, right? Start at the head and you work your way down to their feet. Now, in pediatrics, you cannot typically do a head to toe. In an older kiddo, maybe you can do a head to toe. But usually for infants, especially if they're asleep, you're going to want to listen to their chest first. So heart, lungs, belly first. Because usually once you put that cold stethoscope on them, they're going to wake up and they're not going to be impressed that you're trying to listen to them and you're bothering them while they're trying to sleep. Okay. So you kind of go in the step-based assessment based on that kiddo's development. Okay. Chronological age can be used as the main criteria, but you as the nurse need to figure out that child's specific developmental needs. Okay. If it's a 3-year-old, you're probably going to have to let them kind of ask you some questions, get down on their level, talk with them about maybe something that they'd like, or ask them if they want to listen to you first before you can get, your assessment piece done. This goes back to kind of minimizing their stress and their anxiety, that atraumatic care as a nurse. Okay. By interacting with these kiddos age appropriately and interacting with the parents during your assessment, you build a more trusting parent-child-nurse relationship. Okay. It also maximizes your accuracy of your assessment findings if you're assessing things like their chest first prior to them getting, really angry and screaming, crying, upset. Okay. General approach to examining the child. Obviously, you want to prepare the child. You can see in this picture, the nurse lent their stethoscope to this kiddo to let them listen to their teddy bear. That's one way to get kids kind of, a little bit more involved in their assessment, and that will allow them to be more willing to let you do what you need to do. Okay. Sometimes you have to get parents involved. You have to give them a medication. It's very likely that kiddo, if you go to give it to them, they're gonna, shut their mouth and not open their mouth and refuse to take it. But if you there as the nurse are right there next to the parent and you can get the parent involved in the care of giving that kiddo their medication, then, it's more likely that kiddo will take their medication appropriately. Okay. Age appropriate techniques, but also developmentally appropriate techniques. Okay. Have to think about their age and development. Okay. Which approach would be best to you to ensure a positive response from a toddler? Okay, which one?
A.
A. Yep. Eye level position and talk quietly with them. Okay. Good. You don't want to pick them up because most likely they will throw a huge fit because they don't know you. Okay. If you say, I'm your nurse, and you talk to the toddler by name, a lot of times they're going to still kind of be nervous, right? They're going to think that you have some sharp object that you're going to poke them with. That's usually toddlers. They're very nervous that something bad's going to happen to them when they're at the doctor's office, or anyone who looks like a nurse or a doctor is around. Okay. And if you stand by them and you're talking to them and you're standing over them, then that makes them more anxious as well. Okay. Growth measurements. So growth charts, these are sheets of paper that have 97th percentile, 95th percentile, 90th, 75th, 50th percentile curves, averages. They are sex-based, so boy and girl charts. Okay, so it's looking at that kiddo's percentile of height, weight, head circumference, and BMI based on all boys or all girls their exact same age, how they compare. Okay, so if their growth chart says their length is 75th percentile, that means they are taller than 74 out of 100. If you took 100 kids, boys, let's say it's a boy, 100 boys, their exact age, they would be taller than 74 of the 100, and then 25 of the 100 would be taller than they are. Does that make sense? So that's your growth charts. That's a part of your physical assessment, looking at how they are on their growth chart. You don't necessarily want to compare them to others. You do in a way with the growth chart, but what you want to see on your kiddo's growth chart is that they're staying on their same curve, their own curve. So they're not having big jumps up from 75th percentile to 90th percentile, because that's telling you something's going on. Or they're not having big drops from 75th to 50th, because maybe they're not getting the nutrition that they need to continue to grow. Okay. You're also going to get height, weight, length, head circumference on kids 2 and under. Okay. Your temperature, you want to do radial pulse on older kids, that's okay, but best to do an apical pulse. You want to get accurate respiration rate. Blood pressures should be done for kids ages 3 and up in clinics. But obviously, if this kiddo's in the hospital, they're going to get blood pressures. Okay. You want to make sure you're placing the cuff in an appropriate place. So whether that's right upper arm or leg, on kiddos, sometimes we have to use legs. And you want to make sure that you're using an appropriate sized cuff. Okay. And then sometimes you have to do orthostatic vitals, so to check for orthostatic hypotension. So having that kiddo sit for 5 minutes or lay for 5 minutes, then do blood pressure, heart rate, sit for 5 minutes, adjust, do blood pressure, heart rate, and then stand for 5 minutes, adjust blood pressure, heart rate. Okay. General appearance of the kiddo. Do they look sick? Do they look like they're really, really sick and acutely in distress? Or do they just kind of look like they don't feel very well? You're looking at their skin, you're looking at their lymph nodes, their head, their neck. You're doing all of this sort of stuff before you actually lay hands on the kiddo to examine them. Ears, mouth, nose, chest, lungs, heart. With their abdomen, just like with adults, you want to inspect first and then auscultate and then palpate. Genitalia, if you're going to look at a kiddo's genitalia, I encourage that the parent be in the room. And also you have another employee with you, just for your own protection, safety wise. Making sure that their anus is patent, okay, that they don't have some sort of imperforate anus, so no anal opening or an abnormal anal opening. Their back and their extremities, their joints, their muscle. You're going to do your neurological assessment, okay, so checking your reflexes, the cranial nerves, and then cerebral function by looking at their balance and their coordination. Okay, crown to heel length. Okay, so you're going to do crown of the head to their heel is going to be your length. Okay. Sometimes you'll do chest circumference measurements. Sometimes you'll do belly circumference measurements. Head circumference, you'll do those, like I said, routinely 2 and under. Okay. Your height, you want to make sure you get kiddos feet together and heels all the way to the back of the wall, their bottom touching the back of the wall, their shoulders touching the back of the wall, and then parallel looking forward. Okay, and their head in a midline with the rest of the body to get an accurate height. Okay, so blood pressure, looking at your blood pressure cuff placement, it needs to be 40% of the circumference at the midpoint. So if your blood pressure cuff is like you could wrap it around twice, that's too big of a blood pressure cuff, okay? If it's taking up their entire humerus, that's too big of a blood pressure cuff, okay? So you have to just kind of not only go weight-based, but also how it appears on that kiddo's arm, okay? You can use, these are different positions you can put blood pressure cuffs on and where you can listen to get accurate blood pressures. Doing manuals are actually the most accurate form. A lot of places though are going to, having a machine do the blood pressure reading, okay? All right, chapter 30, pain assessment and management in kiddos. Okay, So children will portray pain differently. Every kiddo will. They might portray pain differently at each visit. Okay. It's hard to assess pain management because not every kiddo will tell you, this hurts or it feels like this. Okay. Making sure you assess the pain appropriately with an appropriate base pain scale, and then you treat their pain, and then you reassess their pain based on whatever form of pain management you gave. Okay. So whatever intervention you did. Okay. Making sure, especially like a post-surgery kiddo who had their tonsils out, you do not want them to wait until they're having the pain to be asking for pain medications. You want to stay on top of the pain. Okay. You can look at systemic monitoring. So you can look at their body language. You can look at their vital signs. Okay. So if blood pressure is going up, heart rate's going up, their temperature is going up, those are kind of some signs to clue you into that kiddo is having pain. Okay. So FLAC is facial expression, leg movement, activity, cry, consolability. So FLAC scale is good to use on a kiddo who maybe cannot, express to you. So like a nonverbal kiddo would be good to use FLAC, an infant, because you can't have them kind of tell you or indicate what's going on with them. Okay, so FACES is a pain scale. You have to use this on a kiddo who is over the age of 3. Okay. So you would just ask them, okay, look at the faces and tell me which face you are right now because of your pain. And then they would point. Okay. Numeric rating scales should be utilized for kids 8 and older. Now, you're doing your developmental assessments on these kiddos and figuring out, are they developmentally delayed or not? That will guide which pain scale you utilize as well. Okay. So like I said, FACES can be used for 3 and up. Numeric scale, 8 and older. Okay. Nonverbal child, use the FLAC scale. Okay. So pain types: chronic, persistent, recurrent. So chronic pain is going to be pain usually for longer than 6 months. Sometimes in certain diagnoses, it's longer than 3 months. Recurrent pain is going to be, they had pain, it got better for a while, and then it came back. That would be recurrent pain. Chronic pain is going to be they've had pain, for a long period of time. Persistent pain is pain every day. It might get better with medication, but it doesn't ever go away like recurrent pain does. Recurrent pain usually goes away and then it returns. Okay. Okay. So like I said, chronic or recurrent pain is 3 months or longer, with some diagnoses 6 months or longer. Okay. So you can look at like chronic daily headaches, complex regional pain syndrome. So something like fibromyalgia or abdominal migraines. Those are kind of more complex pain syndromes that are typically chronic. Okay. So you want to look at their physical functioning. Are they able to do the things that they usually like to do with the pain and still continue to do those things at the same level that they were able to attain prior to pain becoming chronic? Are they emotionally able to function that way as well? Are they still able to have their friends and go do social things like they enjoy? And are they able to still do their schoolwork? Okay, so looking at these specific things to make sure that their pain is being managed appropriately. Okay. Children who are able to communicate, um, or who have communication or cognitive impairments, then you need to look at that kiddo's checklist. So a lot of these kids have pain clues that they can give you, or that you may notice while you're caring for them. A lot of times the parents have these sort of checklist kind of that they're aware of, or some changes in behaviors that you can see with kiddos who are unable to communicate or have cognitive impairment. Okay. It's important to know that different cultures have different opinions on pain. Some have extremely high pain tolerances and some have extremely low pain tolerances. And you have to just kind of be aware and work with that family and that child based on their cultural background. Okay. Kids with chronic illness also likely have more complex pain because they've dealt with chronic illnesses. It's more likely that, they're going to have a higher pain tolerance, or they're going to have more complex form of pain. Okay, so your first goal with pain management, as long as this will be an effective, potentially first step, is non-pharmacologic. So distraction techniques, relaxation techniques like guided imagery, cutaneous stimulation. So that's like a TINS unit. So like the electrical stimulation, that's something that can be used. Containment and swaddling. So swaddling that baby up, non-nutritive sucking. So giving them a passy to suck on while swaddled, okay, or just holding them close to your body, or kangaroo care. So and kangaroo care is, chest to chest with parent. Parent has bare chest, or maybe it's the baby's on their bare chest and they're covered with a gown like this mama here. Okay. So these are forms of pain management, or non-pharmacologic pain management specifically. Okay. Now pharmacologic management. Tylenol or acetaminophen, that's usually the first option. Tylenol or acetaminophen can be given to any infant, any age. Now ibuprofen or Motrin the kiddo has to be 6 months or older to be able to take ibuprofen. Okay. Opiates, those depending on the severity of pain are utilized. So post-surgical pain, kiddos who are going through withdrawal symptoms, so infants who are born to mothers who were utilizing opiates, then they may need some sort of withdrawal kind of pain management medications. So opiates can be utilized in infants as well. Utilizing a PCA pump in kids who are able to hit the button themselves and be aware of their pain and the need to hit that PCA button, or epidural anesthesia as well. Okay. Some kids, you do a transdermal kind of pain. So that would be like an Emla cream or like a lidocaine numbing cream prior to them having blood drawn. Okay. Or an IV placed. This is really helpful in your atraumatic nursing. It's very common that transdermal anesthesia is utilized prior to blood draws or IV placements now. Obviously, side effects of doing topical analgesia or transmucosal analgesia, you have to know kind of what you're monitoring for. So if you're doing lidocaine on a kiddo, and they're getting too much lidocaine and how that would affect them. So you have to be aware of what you could be seeing for side effects. Okay. And like I said, once you do a pain intervention, even if it's a non-pharmacologic intervention, you need to be reassessing that pain intervention on if it was effective, if it helped their pain, did it just sort of help the pain momentarily and now the pain's back and it's worse. So keeping an eye on the effectiveness of your pain management regimen. Okay. Physiologic indicators of untreated pain, like I said, that would be your blood pressure, your heart rate, sweating, all of that sort of thing. Behavioral indicators, that kiddo could be a pretty easygoing kiddo, and then all of a sudden they get really fussy and nothing you're doing can help them out or contain them or calm them down. They have clenched fist. They're an infant with a clenched fist. That's a behavior that can kind of indicate untreated pain. They're more irritable and agitated. Those can all be signs of untreated pain. Okay. Pain in primary care. So you're a clinic nurse. You're going to get calls about vaccination pain. So, discomfort with their arm, teething, ear pulling pain, RSV, so upper respiratory illness stuff. That's usually what you'll kind of get calls in related to pain for primary care. Painful or invasive procedures. So if they went home with a circumcision or they had a circumcision, as newborns and they go home, that's a painful procedure. Open wounds, post-op pain, burns, all of that can be, more difficult to kind of manage. And you'll have to utilize multiple modalities for pain management in those kids. Okay. So for infants, so in the NICU or pediatric unit, if you're doing a blood draw or you're doing an IV start or some sort of procedure that's going to be painful to that infant, they've done studies on the effectiveness of morphine versus something called sweeties, which is essentially sugar water. It's sucrose water on a pacifier. And those studies showed that pain management when comparing morphine to sugar water, they're essentially the same for pain management. So those kiddos, usually the best way to do it if they're having a painful procedure, have their passy in their mouth and just kind of put that little sweeties, a couple drops on their passy while they're sucking on their passy. And you can do that, every minute or two, depending on how much they're needing and depending on the procedure. But that can be a really effective form of pain management as well. Okay, here's another question. Which of the following is an important factor for consideration in understanding the experience of pain in children? So, this question's a little bit tricky. So let's think. Okay, so I'm kind of getting A, so kids cannot tell you where their pain is. I'm getting C, narcotics are dangerous for children. So it's actually B. So kids, think about kids. They're in a hospital, they're scared. They're scared of what's going to happen. They think every time they say anything, they're going to get a shot, right? Or they're going to get swabbed for strep throat, which hurts. Or they're going to get swabbed up their nose for RSV or for flu. Okay. So it's not uncommon for kids to say that they do not have pain because they're scared of what is going to happen if they say that they have pain. Okay. Most kids can point kind of a general place of where they're hurting. They may not tell you specifically. Okay. But they can kind of indicate somewhere. Even, I mean, I'll have 2-year-olds. You ask them, okay, your ear's hurting, which ear? And they'll point. Now, of course, developmentally, you have to be aware of where that kiddo's at, but usually they can tell you in general where they're hurt. Narcotics can be dangerous in high volumes if it's not weight-based, but narcotics are utilized in kids as well. Like post-op kids are going to be on narcotics while they're in hospital. They're weight-based specific, so there's not as much risk for overdose. Okay. And kids are just as sensitive to pain as adults. Okay. All right, so now we'll go to the Kahoot. Stop my screen share here. Okay, do you guys have any questions from any of that material? We have about 20 minutes left. We kind of zoomed through it. No? No questions? Okay.
I have a question just about the class.
Uh-huh.
So for like the YouTube videos that you have, is that going to be this like PowerPoints that you went over, or are you kind of just taking those topics and I don't
It will
know.
be what we record in class. Yep. So whatever we do for class.
Okay.
Yep. So what we have right now going on is what will be on the YouTube video, what I record for class. Okay. Let me get the Kahoot going here. There are some handouts under the week 1 post that talk more specifically about the theorist. We'll also go more in depth of that when we cover each age group of kiddos. So each developmental age. So when we talk about infants, when we talk about preschoolers, when we talk about school age and adolescents, we will go more specific into detail for each of those categories in the next week and in the next 2 weeks. Okay. But there's handouts in regards to the theorists. And then there's another handout on there too that you guys might find helpful. Okay. And if you have friends or classmates that are in other sections, and for some reason they're getting some sort of extra handout, let me know and I'll reach out to that professor for that for you. Okay. Okay. Once I get the pin here, I'll share. Okay. Let's screen share here. Oh. And the link to the Kahoot is also in the announcement as well for each week. Okay. All right, if you guys can join me on here since we're still in class for about another 15 minutes, okay? Haley Butler, if you can turn your camera on, please. I've already sent you a chat about it. Haley, can you turn on your camera, please?
Yes, ma'am. Can you hear me?
Yeah, I can hear you. I just can't
Okay,
see you.
that's I'm sorry, I was muted.
Okay.
I've been trying to because I don't know why it's not showing. Because at the bottom of my screen, it's saying that it's on. I mean, and even my camera is lit up on the top, so I don't know.
Do you have like a cover or something over your camera?
I don't have anything over it.
Okay. Try logging out and logging back in, and we'll see if that will work.
Okay.
Sometimes Zoom has some weird kind of glitchy things that it does. Okay. Go ahead and get started here. Okay, so here's our week 1 material over what we just talked about. Some questions. Yeah, I still can't see you, Haley.
I don't know why it's not allowing you to.
Let me see if I stop video, if it will let me do it. I'm gonna mute you though really quick, okay?
Okay.
Okay, so leading cause of death from unintentional injuries in children is motor vehicle fatalities. Good. Yeah, Haley, I still can't see you. So I don't know if you can talk to IT.
Okay, I'm
need to update something on your end.
okay.
But you can stay on for now, but we need to figure out your camera so you can get attendance credit.
Yes, ma'am. I'm getting my husband to look at it real quick while I'm going over the questions because he's in IT actually, so maybe he can get it working for me.
Okay, awesome. Thank you. Okay. Okay. Which statement is most descriptive of pediatric family center care? So it involves the family dependence on the healthcare system. It encourages the family that is the constant in the child's life. It reduces the effect of cultural diversity on the family. It avoids families to be a part of decision making. Yes. To family-centered care in pediatrics is recognizing that the family is the constant in a child's life, and that family is whoever that child feels that the family is.
I keep getting disconnected from the Kahoot. I don't. Yeah, like it'll say it's reconnecting, and then I don't know.
And it's not letting me play.
It's not letting you play?
Yeah, like the squares will pop up, but it's just don't let me click anything or play.
Can you do it on your phone?
Okay, let
You can try that. You should be able to join. The game pin still down at the bottom. So if you just go on your phone to kahoot.it and then do your game pin, that might work better. Okay, so major cause of death in children who are older than 1 year is unintentional injuries. Okay. Younger than 1 year, what is the major cause of death? Usually.
Low birth weight.
Low birth weight is a factor.
SIDS.
SIDS. What else? Abuse, intentional injuries. Okay. Okay, the nurse is caring for a child in pain, understands that distraction can give total pain relief to the child, is the best method for pain relief, is effective when the child is in severe pain, or must be developmentally appropriate to refocus attention. Yes, developmentally appropriate to refocus the attention. I will give you guys this little hint, I guess, for quizzes and exams. If it says something about developmentally appropriate, then I would be rereading that question again and then probably picking that as the answer. Okay. You want to make sure whatever you're doing is developmentally appropriate for that kiddo. And what type of play are children engaged in similar or identical activities without organization or a mutual goal? Solidarity, associative, parallel, cooperative. So remember, that's the associative play. So they're playing the same sort of thing, but they don't have the same goal. So they're playing with Legos, and one wants to build their castle this way, and one wants to build a farm. Okay, does that make sense? The cooperative play is they are building the same thing with the same goal. So they both want to build a castle, they're building it together. Or they're playing a game of chess and, you know, they both have the same goal of winning. Okay. Which statement best describes the process of critical thinking? It is a simple developmental process. It is based on deliberate or rational thought. It is a purposeful and goal-directed. It assists individuals in guessing what is most appropriate. Yes, critical thinking is purposeful and goal-directed. So you have goals and a common purpose in mind, and it helps kind of direct your thinking. Okay, what is probably the single most important influence on growth at all stages of development? Culture, hereditary, environment, nutrition. Nutrition. If those kids aren't eating and getting the nutrients that they need, then all of their stages of development and their growth and their gross motor development, their fine motor, and their speech, that's all going to be affected. Okay, if they're not getting the nutrients that they need to grow and develop. Which function of play is a major component of play at all ages? Creativity, intellectual development, socialization, sensory motor activity. Okay, sensory motor activity. Okay. That's a huge component in play for kiddos of all ages. Okay. I like that you guys picked intellectual development. That's also something to be thinking about with play at all ages. But as far as the function of play is the sensory motor activity. Okay. Good. How do you apply nice satin to an infant with thrush? This kind of goes into next week's material. Squirt it in the side of their mouth with a syringe. Use a cotton swab and coat the area with medicine. Use a medicine cup or use a teaspoon. Use a cotton swab and coat the area. Yep. You try and squirt nystatin. I don't know if any of you guys have smelt how oral nystatin tastes, or when you've put nystatin on a patient's rash or something, how it smells. It doesn't taste good. So usually if you try and squirt it in the kiddo's mouth with a syringe, they're going to start gagging at you. So using a cotton swab and coating that cotton swab with the nystatin and then applying it directly to the area of thrush is the best way. 3 children playing a board game. What would this be an example of? Solitary play, associative play, parallel play, or cooperative play? Cooperative play. Good. Head to tail direction of growth is referred to as head to tail. Cephalocaudal. So head, ceph is head, and caudal is for tail. So head to tail is cephalocaudal growth. Okay. What is the single most important factor to consider when communicating with children? The child's physical condition, the presence or absence of the child's parents, the child's developmental level, or the child's nonverbal behaviors. Yes, good. Child's development. Good. What 2-year-old child pain assessment tool should the nurse use? Faces, Oucher, numeric, or Fleck? Which pain scale would be appropriate to use for a kiddo who is 2? So remember, ages 3 and up, you can use the faces. If they're less than 3, then you need to use the Fleck scale. Okay. Because developmentally, most 2-year-olds, they'll just point to whatever when you ask them to use the faces scale. And at 3, they can kind of understand, a little bit more of the emotions that are on the faces scale. So you'll have to use the Fleck tool, which is looking more at how their face is looking, are their legs scrunched up, are they able to be comforted and consolable? Okay. Good. At 6 months, an infant's birth weight should this is also more specific to next week. We'll go over this material next week when we talk about infants. But yes, good. Double by 6 months, triple by a year. Okay. For birth weight. Good. The first expected fine motor developmental milestones for an infant begins with voluntary palmar grasp, neat pincer grasp, reflex palmar grasp, or putting objects in a container. And this also will be talked about more specifically next week. So don't freak out if you aren't so sure on this developmental milestone yet, okay? Reflex palmar grasp. Okay, so think about a newborn. What happens if you put your hand or your finger in their hand? They grab it, right? And parents think, oh, that's so cute and so sweet. And they think it's like the coolest thing ever. And then we all know as nurses, that's just a reflex. Okay? But don't tell your parents that because they'll be sad about that. Okay? But that's just a reflex. Okay, do you guys want to keep doing these Kahoots or do you want to be done? You're all bored from all the PowerPoints.
We've been in class since 8.
Oh my gosh. Yeah, I would be over it. I don't blame you all at all. That's not fun. So do you have all your courses then in one day?
We have med-surg too on Monday mornings, and then we get just a brief break, and then it's straight into pediatrics.
What campus are you guys at?
It's the same for Cincinnati too.
I was gonna say,
Oh man.
it's like that too.
Oh my gosh. And all your exams are going to be on the same day too.
I was gonna ask, do we have options to change class and days? Because I know for maternal we did.
Yes. So Dr. Brown posted in the announcement section within the Canvas shell about wanting to change. So just look at that announcement. I think it just posted today. But I can see it in there.
Yeah, what's it under? Because I don't see it anywhere.
Let me see. Let's see. Should be under.
Yeah, for announcements, we just have the syllabus, the welcome, and the ebook.
Okay, never mind. I can see it. It will post on October 8th, but sorry, I thought it was already open for you guys.
Thank you.
Yep. So you have to wait until it's published. So as soon as that post, then you guys can talk to Dr. Brown and see about in your campus and see about switching your section. So that'll post it at midnight on the 8th on Wednesday. So Wednesday during the day, you can talk to Dr. Brown and you can also talk to your campus about flipping things around.
You might not have anybody if we all are doing this all day.
I know. Gosh. But that's horrible. I don't blame you guys at all. It's too much. But nursing school.
It'll probably be better to keep it that way.